Welcome. I'm Shami Mahmood from the University of California, San Diego, and the president of SCAI. And I'd like to welcome everybody to this webinar that we're hosting in partnership with the Canadian Association of Interventional Cardiology. This is amongst a series of webinars that we're hosting together. This particular webinar is focused on the care of myocardial infarction patients during the COVID-19 pandemic. Let me first start off by introducing my co-moderator, David Wood from the University of British Columbia in Vancouver, Canada. He's also the president of the Canadian Association of Interventional Cardiology. In addition, our panelists include Tim Henry from Cincinnati, Cindy Grinds from Atlanta. I'd like to also see if Perez can put up our slides. We have Perez Mirage from Northwell in New York, and Fred Welt, chair of the ACC Interventional Council from Salt Lake City. Next slide. These are our standard disclosures for all of us. Next slide. This is a CME program. Next slide. And the recording of the webinar will be available both on the SCAI website as well as the CAIC website. Next slide. We are grateful to Medtronic for an unrestricted educational grant enabling us to host this webinar. Next slide. So this particular webinar has really originated from this publication that was jointly published in CCI and JAC earlier this week. It was a combined effort between SCAI, the ACC Interventional Council, and the American College of Emergency Physicians. And we felt that this was the right time for us to come together and issue a consensus statement on the best way to optimally treat myocardial infarction during the COVID-19 pandemic. Next slide. So I'm going to start off highlighting the three key messages from this manuscript. This is our key figure from the manuscript, and what we want as a key takeaway point is that when ST elevation patients come into the emergency room, in the current era, when we are contemplating the possibility of a COVID-19 positive or probable patient, then in those patients there can be many etiologies of ST elevation. However, the best way to figure out how we can treat those patients expeditiously is still by going to the cath lab. For patients who are positive or probable, we do recommend consideration to a point of care ultrasound, and as long as a wall motion abnormality in the presence of classic symptoms of myocardial infarction matches the wall motion abnormality, the patient should go straight for primary PCI with appropriate PPE. In patients who are COVID possible, and that in some ways we feel should be all patients until we know otherwise, should be taken for primary PCI with appropriate PPE. When ultra-rapid tests are available, they should be checked early. And I can tell you at UC San Diego, we can get an answer now in 15 minutes, so we are doing that routinely. In the absence of that or equivocal diagnoses, that's when additional imaging, which could include echo, chest x-ray, maybe a CT, to determine whether or not the patient is likely having a true infarct or are there other etiologies for the ST elevation. And that can then be a joint decision whether a cath lab is activated between the emergency department and the cath team. Next slide. So we have come out unequivocally to state that during this pandemic, patients brought in by EMS should not directly go to the cath lab. There should not be field activation of the cath lab, but in fact, the patient should be coming to the emergency room for a 2x2 evaluation. And what do I mean by that? First, to assess their COVID status, and second, to confirm that the ST elevation is likely from an occluded coronary artery. And in that, once those evaluations are completed, then if the patient is high likelihood to be a COVID patient, they go to a dedicated COVID cath lab. Otherwise, they go to a standard cath lab, but PPE universally for the entire team during the whole process. Next slide. As far as patients coming to a referral hospital, if they can get to a primary PCI center within 120 minutes, just like our guidelines have previously suggested, they should be transferred for primary PCI. If that's not possible, then fibrinolytic therapy followed by transfer for either a pharmacoinvasive or rescue PCI approach. But the second important point is once they come to a primary PCI center, the patients should be rescreened for their COVID status and confirm that the ST elevation MI is likely the actual diagnosis. The one other important fact to remember is that it appears that a myocarditis associated with COVID-19 is much more common than with any of the other viral myocarditis presentations. So we're not sure how true that prevalence is, but that's one of the STEMI mimics to think about. So with that background, let me turn it over to David Wood, my co-moderator, who it's been a pleasure to work with, and we have really felt that in the last few weeks we've been able to bring our organizations together around educational activities and research activities. David?
Thanks, Shami. Definitely, I think we've all seen that interventional and structural cardiology has never come together like it has in this last month, and I think we're all learning from each other. I think the first topic is going to be primary PCI, and this was hotly contested when we were working on the Canadian guidance document about what threshold would you tip over from maintaining primary PCI to fibrinolysis, why primary PCI made a lot of sense logistically, and we landed in a very similar way that you did on your document. So without further ado, we have an amazing panel. Dr. Cindy Grimes maybe can chat a little bit about primary PCI and why it is still the focus in this guidance document. Thank you.
Thank you, David. The reason that the first slide did not show any thrombolytic therapy when patients are arriving directly to the tertiary care center where you have a cath lab is for a number of reasons. And we've heard a lot of hospitals in the community and even some academic centers have been giving a lot of thrombolytic therapy. And unfortunately, we spent the past 20 or 25 years trying to convince the medical community that primary PCI was superior to thrombolytic therapy. And in only 20 or 30 days, it seems that we have completely reversed course. And so that's why I thought it was important to go through thrombolytic therapy compared to primary angioplasty, and particularly since many physicians who did their fellowships within the past 20 or 25 years may have never even administered thrombolytic therapy. Now, there are a number of limitations of thrombolytic therapy. First and foremost, many patients aren't eligible due to absolute or relative contraindications. But even if you give thrombolytic therapy, it doesn't work that effectively. Patency rates and TIMI-3 flow rates range from about 55% and at best are only 70%. And that's if you're combining it with clopidogrel and using the top-notch medications available. And even if you give thrombolytic therapy, 30% of them may need to go immediately to the cath lab for failed thrombolysis, which of course is incurring cost and bleeding complications. And with successful thrombolysis, those patients will ultimately end up in the cath lab in the next day anyway, which totally incurs the cost and doesn't necessarily protect you or your staff from doing that procedure, because that's what the guidelines say to do. And so because of all these reasons, I think it's important to go straight to the cath lab. First of all, we know from several randomized trials and meta-analyses that primary angioplasty compared to thrombolytic therapy results in a 30% reduction in mortality, a 70% reduction in reinfarction, and a 95% reduction in intracranial bleeding. Also, it's associated with shorter and less complicated hospital stays. And if we're using the reason to give thrombolytics because you don't want to occupy ICU beds, then you definitely should not be giving lytics. You should really think more in the terms of primary angioplasty. And then I'll just finish with one of the most important reasons I like primary angioplasty is you have an initial angiogram that allows you to diagnose and triage patients to the most appropriate treatment. And as Shami mentioned, there could be some patients who have focal myocarditis. There could be patients with Takasubos. And do we really want to subject those patients to the risk of thrombolytic therapy without any potential benefits whatsoever? And so I think that it's primary angioplasty really in the vast majority of cases, unless they're going to have a delay in transfer from an outside hospital.
Great, fantastic, Cindy. So maybe we'll, before we get into questions, let's put the other aspect of things into perspective, and I'll ask Fred Welch from the University of Utah, also the chair of the ACC Interventional Council, to comment on when should we be considering fibrinolytic therapy, and how do we handle this with respect to referral hospitals?
Thanks very much, Shami, and the rest of the crew. And so I'll just amplify a little bit of what Dr. Grimes has already talked about. She mentioned that a lot of us don't have a lot of experience with thrombolytic therapy who've trained in the last 20 years. And that was certainly my case when I was in Boston, which is a little bit ironic because, that's where the STEMI group was founded. That's where Dr. Braunwald sort of introduced thrombolysis, but I'd really never seen it until I moved to Utah. But the difference here, of course, is that there is not a cath lab on every corner. And in fact, we serve about 5 states, very rural areas with limited resources. And so we get a lot of transfers in from these sites with STEMIs where we really can't reasonably meet that 120-minute sort of deadline for door to balloon. And so lytics obviously have a role in that situation. And it's, as with any medical decision, it's a balance between the risks of delaying reperfusion versus the risks of thrombolytics. And Dr. Grimes had talked about a lot of those. A lot of them are efficacy, failure to reperfuse, or reocclusion. And then what we often see, of course, is that even when patients have had successful reperfusion, we don't have TEMI-3 flow. We know that's well correlated with better outcomes. And then, of course, the safety issues. And we've seen every complication of lytics now, including access site bleeding. We've seen hemopericardium from patients with pericarditis who've received lytics. So it is really eye-opening to see the complications that can occur. However, I think that obviously, given the distances that we deal with, and which I'm sure a lot of other places do, lytics do make sense in many situations. And of course, that has to do with the length of time to get to a cath lab and get the definitive therapy. I think, the important thing for referral hospitals is really to have a well-coordinated regional program for STEMI care. And that's true in the best of times. And I think it's even more true in the era of COVID, where you really need to be coordinated. I think the strength of a coordinated program is, of course, our protocols that are standardized and that everybody understands sort of what the standard of care is with that referring institution. So I think that in general, when patients present with, clear-cut signs of a STEMI, that thrombolytics are very reasonable, if you can't get to the cath lab in time. COVID introduces some new issues that I think we have to deal with. And one of them is what's already been discussed, is the uncertainty of the actual diagnosis. So a lot of people have talked about using other devices like point-of-care ultrasound, et cetera, to look for some regional wall motion abnormalities to sort of make the diagnosis a little bit more certain before you give lytics. I think careful discussions with those referring hospitals, a thorough history about any sort of other associated symptoms that might suggest COVID are reasonable. And in certain circumstances, you may want to withhold lytic therapy. So I think, the really critical issue, I think, is coordination of care and discussing these issues with your referring hospitals now, before you start getting these transfers. And we've done that just to understand, what is available at that hospital in terms of diagnostic procedures that might help you in this process, but also just have an understanding of what we're facing and how we're going to actually deal with these specific patients when they come in. So those are my general thoughts.
Thanks, Fred. That was wonderful, both you and Cindy. And I think that highlights a point. First, please put through your questions, because that is usually the most interesting part of these podcasts and webinars, is the last 20, 25 minutes. And second, I think a key point that Fred just made, if you are from a region of the US or Canada that already has infrastructure in place for pharmacoinvasive or thrombolysis with transfer because of great distances, that is very different than a region that's suddenly going to start doing thrombolysis for the first time in many, many years because of COVID. And I think we'll touch on that. But let's change gears now. And this has been a very challenging area. And I'm glad we have someone from New York who can speak to this. When you have patients who cannot give a history, out of hospital cardiac arrest, cardiogenic shock, Perwaiz, what should we be doing and what does the guidance document state? Thanks.
So thank you very much, and it's a privilege to be on this great webinar. And it's a great question. I think we in New York have unfortunately experienced the biggest hit, and I don't wish it upon anybody. I hope everybody else can stay away from the insane surge that we had here. But if you look at from the perspective of out-of-hospital cardiac arrest, what we have seen is an extreme decrease in people who are coming to the hospital without a hospital cardiac arrest. I think that we've seen actually a significant increase of patients who are found, unfortunately, dead at home or not trying to or unable to obtain care for whatever reason that may be, just purely because of the inundation that we've had to the healthcare system here in the New York area. And similar to those who are in cardiogenic shock, we haven't really experienced too many cardiogenic shock patients. The majority of our patients have been primarily distributive shock from the coronavirus pneumonia and the cytokine storm that occurs. But however, there are a small minority of patients who come in either with fulminant myocarditis or in cardiogenic shock as a late phase of their COVID pneumonia or COVID septic shock. And these are the patients that have been very difficult for us to really understand what the best strategy has been. What we have suggested is that we are going to try to treat every patient as best as possible, as much as our hospital system can endure. And unfortunately, we have fortunately been able to take care of the majority of these patients. However, those, as we would deem anyone reasonably safe and sound prior to the COVID era, for someone who was either a cardiac arrest or in cardiogenic shock, didn't have comorbidities or other issues that would otherwise preclude them from getting therapy, we sort of treat them the same way now, in the sense that just because they have COVID doesn't mean we're not treating them. The reality of it is that if we feel that they're COVID pneumonia, they've been intubated for a week or 2 weeks and what have you, and they've shown every sign of failure to proceed or progress, we have not been able to provide those patients with advanced care. And I think the key is to really do it on a case-by-case basis. And I think that's really what the document is suggesting and telling us. There's no broad sweep and broad brush stroke that we could say every patient with COVID should not be treated or should be treated. That would not be the accurate way of describing it. It's case-by-case basis, looking at every comorbidity the patient may have and what their likelihood of success or failure may be going forward in their hospitalization. So cardiac arrest, unfortunately, we have seen some cardiac arrest patients. Unfortunately, most of them, if not all of them, pass. They have not survived, especially if it's due to COVID pneumonia or due to hypoxic respiratory failure. And when it comes to cardiogenic shock, we've had a couple of cases of myocarditis early on. Fortunately, that myocarditis in a few of those cases were due to the COVID pneumonia and the worsening of their COVID pneumonia and their cytokine storm, and they actually succumbed to their illness as well. And we have not seen significant cardiogenic shock in the early stages of the COVID illness.
Great, thank you, Perwaiz. We'll come back to some questions after this next clinical scenario. So the final one, we'll have Tim Henry tell us about how to manage STEMI patients during this COVID-19 pandemic. Where do we arrive at, and what are the data behind the STEMI patients?
Thanks, Shami and David, and certainly delighted to be here tonight. So I think this is a complex topic, and I'm going to split it into two areas. So number one is troponin. So the measurement of troponin, and first of all, I think that if you look at patients who are COVID positive, it appears that are hospitalized, about 15 to 25% of those patients will have an elevated troponin. There's some controversy about this because the ACC.org actually had a recommendation on the website that you not measure troponin. And I think this has changed over time, that we know that the troponin itself is a very strong predictor of poor outcome. The cause of the elevated troponin can be multifactorial. And I think so, first of all, I think currently we recommend liberal use of troponin, not only on admission, but throughout the hospital stay if patients significant change. So I think that's number one. Number two, it's important to step back and say all troponin is not a non-ST elevation MI from plaque rupture. So I think a second key point we know from non-STEMI is that patients benefit from an invasive approach. So our standard of care throughout North America has been when you have a non-STEMI, to do an invasive approach and goes to the cath lab. And I think it's worthwhile in this period of time to step back a little bit. And I think the document dealt with it. And I would say the best thing that we did was flexibility. And I think it starts with this, with the same principle as primary PCI. If you have a patient with a non-STEMI that you feel is plaque rupture with, and consistent with coronary artery disease and has high risk features, that patient should go to the cath lab. I think there's no doubt about that. We are unequivocal about that. But then I think the second one is if you have patients who have unstable angina or who have low risk non-STEMI, a bump in enzymes, then I think it is worth time and consideration. And so we built that flexibility into the document. And I think the things that matter are, what are the patient's symptoms? What are the cardiac risk factors? So what are the probability that this is plaque rupture? What's the LV function? And then importantly, in that situation is, what are the likelihood that they have COVID or not? And I think that if you feel like this is a patient that is stable and low risk, that it's reasonable to do secondary prevention and delay the cath with risk stratification. Another key important point is, depends on the prevalence of COVID in your region. And second of all, the ability of rapid testing. So again, this is going to be a changing thing, because as it gets to the point where we have rapid testing and you have a patient with non-STEMI that you know is negative, then I think we can treat them the same way we did before. So I will stop with that, say troponin makes a difference, use it liberally in terms of high risk identification. But just like always the case is, you have to use judgment on whether the elevated troponin is really consistent with a non-STEMI. High-risk patients should go to the cath lab just like always, but low-risk non-STEMIs, take some time and be thoughtful about it depending on your circumstances.
Great. Thanks, Tim. So it sounds like, if I were to paraphrase that, is a high troponin, bad prognostic marker, but doesn't automatically buy you a trip to the cath lab in this current era.
Yeah, absolutely. I think that's really important, is that, in fact, if you look at the 15 to 25% of COVID patients who have a positive troponin, the majority of them do not have plaque rupture that requires PCI. So there's lots of mechanisms that will lead to it. So the troponin helps to identify high-risk patients, not to tell you who goes to the cath lab or not.
Perfect. So maybe what we'll do here is take some questions, David, because we have some fantastic questions already coming in from the audience, and we've discussed 4 clinical presentations. Fred, why don't we have you take this question? If a patient has received lytics, then should they all go to the cath lab once they've arrived at the primary PCI center relatively urgently, or should you wait up to 24 hours?
So yeah, it's a great question. Of course, sort of the standard care that we have delivered, at least up till now, is that when we get a call from a transfer center, we, regardless of whether they're getting lytics, we actually call the cath lab team in and we wait. And the patient arrives and goes directly to the cath lab. And then we make a determination about whether they have successfully lysed. And that's, generally resolution of pain and at least 50% reduction in their ST segment elevations. And the only caveat there, of course, is that when they're in the first 2 to 3 hours after lytic therapy, that's a time point where the studies would suggest, obviously, that you have increased risk of poor outcome if you just routinely go straight to a catheterization and potential angioplasty. If you have continued ST segment elevations, then by all means, you just need to go ahead. I think that in the COVID era, that largely still applies, but there are some issues there that I think are important. I think that, and the patient where you really strongly suspect that they are COVID positive, then you may want to sort of walk that back a little bit, especially if there are signs that the patient has successfully reperfused. But in general, I think that we're still approaching these patients the same way, except that, of course, we are protecting ourselves with PPE. And I'd be interested to see if Dr. Grinds or others have sort of a different sort of approach to that.
No, I think that's a very reasonable approach, to be honest. The only caveat is that if those patients are eventually going to get a cath and you've already called the team in at 2 in the morning, do you really want to send them all home and then do the case at the following day? So what I have resorted to, if we're all there and the patient's going to require a cath anyway, perhaps go ahead and do it at that point in time.
Mm-hmm.
That's great. Tim, there's 3 or 4 questions that have already come through on your segment. I'm going to try and summarize that. How are you now incorporating elevated white count, decreased lymphocyte? Are you doing Ddimer? How is that swaying you in your treatment algorithm?
Yeah, so it's a really good question. Another issue, and I think about COVID, is we're learning a lot about the disease. But one thing that it's clear that there is a coagulable state, and so the D-dimers have been elevated, and then there's been incidence of increase in DVT and increase in thrombotic lesions in the cath lab. So it's definitely need to be available, or you need to be aware of it. And so the answer is, again, for both, I think, troponin and D-dimer, in patients who are COVID positive or suspected, we're measuring it routinely so that we know about it. The issue about whether you should use anticoagulation in a COVID positive patient is a little controversial right now. There's several trials ongoing, and I think that a lot of people are doing it and putting it in pair, but I would tell you it remains controversial.
Okay. Here's a question that we keep getting a couple of times here, and Cindy, I'm going to have you take a stab at this.
Okay.
The question is, yes, we know primary PCI is superior to fibrinolytic therapy. However, we won't have the answers even with a rapid test. Patients likely having a STEMI, but the delay that it takes in appropriate PPE for the entire team and the effects that might have on door-to-balloon time, how do you reconcile those factors?
Well, I think when we talk about extensive PPE, it's usually in the patients who are definite COVID or the highly probable COVID, where you're going to take a lot of time doffing and downing. And in the absence of that, what I think we should do is use appropriate PPE, have the patient wear a mask, do what you can to try to limit exposure. Everybody in the lab should be wearing a mask from the minute you see the patient. And what I like to do is I wear N95 masks. I just save it and reuse it and put a regular surgical mask. I'm also double gloving and trying to do what you can to completely cover yourself. I know in Italy they were double gowning as well. And so I think you can take those kind of precautions. Oh, and I always wear my lead glasses and splash guards as well. So you have a mask that has a splash guard in front of it. I don't put the whole headset and the entire moon suit on for every patient. But I think we have to keep in mind that we don't know the prevalence in the community. It's thought perhaps, I saw something from New York where it was maybe 13%, but in other communities it's going to be lower. And the chance of you having a COVID positive STEMI isn't as high as you might think. And so we need to take care of the patient. We know the patient's more likely to die from their MI than to die from COVID. And so I think that as physicians, we should do what we think is best.
Completely concur. I think the one unequivocal conclusion is the era of doing cases without any masks or eye protection, which lots of cath labs were still doing. That era should be over for everybody universally.
Mm-hmm.
So David, what do you think? What are you doing in Canada? What's your take on it?
Yeah, so absolutely. I think the thing that we keep seeing here from the comments I think there's about 15 that all kind of go under the same theme. It's an oxymoron, but it's a regional pandemic. And we've learned that from all these different webinars. We've learned that in Europe and North America and around the world, that different areas may have avoided the surge completely and are now going to operate in this plateau for an indefinite period of time. And how do they ration their PPE use? And what does that mean as far as the appropriate level of PPE? I'm going to put this right back to you, Shami. There's a comment here from one of the participants. We have several hundred. In their hospital, all STEMI patients are considered people under investigation. And in the comment here, it says, as per their hospital policy, they intubate all STEMI patients currently prior to the cath lab. What are your thoughts on that?
Oh. I would say the first comment is not unreasonable. We intentionally did not use the term PUI in our document because we felt that, and we took the terms positive, probable, and possible. And so I would say the way this hospital is addressing it is that everybody's COVID possible, and we endorse that. Intubating every patient beforehand would almost be the opposite of what we would endorse. I don't think that that's appropriate or indicated, and we certainly don't want to treat the majority of our patients in a way that is moves our entire standard, because that's not necessarily data driven. So I would say intubation in everybody, no, but consideration of most patients as COVID possible is appropriate, but it does have to be taken into account where you are in the country and what the local prevalence of the disease is.
Could I comment on the intubation? Because there's a huge amount of physicians out there now that believe that we prematurely intubating the patient is very harmful, even if they have COVID positivity. And many pulmonologists are doing, and critical care doctors are doing everything they can to avoid intubation. And so they're giving them 14 liters of oxygen. They're putting them on their stomachs. They're flipping the positions around. And those patients appear to be doing much better than those patients who were so-called prematurely intubated. And so I absolutely would not do that going into the cath lab unless the patient had clear-cut needs to intubate.
Maybe, Paris, we can have you opine on this, because you've directly taken care of a very high volume of COVID patients in New York recently, including using ECMO, hemodynamic support, and primary PCI. What are your thoughts, and how did you handle it where the prevalence of the disease was clearly very, very high?
Right. So I think the first and foremost point, I think the comments are absolutely accurate. This is absolutely regional. So in our region, our prevalence is so high, and we absolutely take care of every single patient as if they are COVID positive. And with 30% false negative rates of the testing, and people who have initially tested negative, then later in their hospitalization test positive, it's clear that every patient is being treated as if they're COVID positive. So we are doing full PPE for all of our physicians and staff, from the entry to the door to essentially their cath lab, or if they're in the ICU or if they're on the floors, it doesn't really matter where they are. When it comes to taking care of straight standard STEMI patients, if again, our criteria is that we've sort of developed this criteria unofficially, where we take care of all STEMI patients who present with a STEMI as if they have a STEMI, whether they're COVID positive or they're COVID negative. We have noticed that there's clearly a pathologic difference between these patients in the sense that the COVID positive patients are so much more thrombotic than the COVID negative patients. And we have a lot more no reflow, more issues, and it's not just our center, but it's the entire New York region that can attest to this. And the anti-thrombotic events and thrombotic use, and in terms of even using lytics in IC lytics, which we've never done prior to all this, to try to help the situation, and it doesn't always help the situation. So that patient population is clearly different between the two, but we try to treat everyone as they walk in the door, if they're walking in with primary STEMI symptoms or STEMI EKGs and clinical findings, as STEMIs. It hasn't always worked out successfully for us and for the patients. The other factor is that, you know, when we're talking about the care of these patients going forward, is that the testing that we're doing on prior to their arrival to the cath lab is more just to figure out where they're going to go in the hospital, because we've converted the entire hospital to COVID beds. And so the ability to find a non-COVID bed for some patients is very, very difficult to find. So it's really, we're trying to maintain the standards of care that we've always maintained. We've been fortunate because our elective volume has been very low, and because we canceled all our elective cases weeks ago, that our cath lab is not inundated. It's the hospital that was inundated. So taking care of these patients, whether they be on ECMO, whether they be on non-ECMO, really it's just trying to take care of them in the best way possible. We've created some criteria because of resource allocation. It's not that we have unlimited resources to put every single patient that we can on ECMO. So obviously we have to resource allocate carefully. But PPE is of primary importance, and we can't stress that enough in this region.
So
we have some very specific questions for you, especially in a region with a very high prevalence of COVID. And they're very pragmatic, and we didn't get to them on the prior webinars. One is, are you using a different ACT cut point? Are you doing a different antiplatelet anticoagulation strategy? And we've heard about doing point of care ultrasound to look for wall motion to try and differentiate this STEMI mimic COVID positive patient. Where were you doing that? Were you doing it in the cath lab or in the ER? So ACT, anticoagulation strategy, and if you're going to do a point of care ultrasound, where are you doing it?
Sure. So I'll start in real time. So when the patient arrived to the ED, as our documents clearly stated, we follow this very closely, and every single patient did a pit stop in the emergency department. We did a point of care ultrasound, as well as got their COVID swab. In the early days, it took forever to get those COVID tests back, but we didn't wait. Nowadays, it's a lot quicker. But the point of care ultrasound was done right in the emergency room, and the determination was made based on the information that we received as to whether or not we would take them to the cath lab or not. It always isn't the most helpful situation because it can be sometimes confusing and sometimes muddy the picture a little bit, but when it's clear cut, it's clear cut. Then when we brought them to the cath lab, in terms of the antithrombotic drugs that we used were typically a heparin lab. We used the typical doses of heparin up to 100 units per kilo of heparin for the PCI procedures, and kept our ACTs in the typical range of around 300. We didn't use higher ACT levels. We did not see any evidence of higher thrombotic events in our catheters or equipment, or for that matter. We just saw the patients having higher levels of thrombus burden and distal embolization phenomenon and small vessel phenomenon. There were some cases in whom the STEMIs were brought to the cath lab and they had no epicardial occlusive arteries, which we know those are the STEMI mimickers that we have been all been reading about and hearing about, and they definitely exist. And their EKGs look like classic STEMIs that you would see prior to the COVID era. In terms of the oral P2Y12 inhibitors, we were typically using exactly what everyone else would be using. It would be aspirin and ticagrelor in our typical patient population, and we didn't really change that too much. The one thing that we have definitely increased our use in the COVID patients is 2B3 inhibitors, the use of other IV like cangrelor and other drugs to that effect to try to help reduce the thrombus burden in these very prothrombotic patients.
Prabase, can I ask you a question about ticagrelor? There is an ISAR study showing dyspnea occurring with ticagrelor. Are you thinking about switching to procedural, especially in face of the ISAR study, which showed it was superior in ACS patients?
Sure. So we haven't actually actively done that. We've seen about what the reported rates have been, about 10% of just patients on ticagrelor getting dyspnea. That's I think everyone's been seeing. We haven't actively switched. We have been using more procedural with the more recent data, no doubt about that. But we haven't actively switched.
But, and can I add something, Shami? I think, hopefully everyone's seeing there's a consistent theme here, is that in general, we have outstanding data on how we present people. And as a general rule, we should stay with that standard. So I think, first of all, we know that with STEMI and non-STEMI patients, that they benefit from either ticagrelor or prasugrel versus clopidogrel. And so certainly that's something that you should be doing here. And then I do think that if for the patient who is unable to take oral agents or get appropriate thing, especially if you have a very thrombotic lesions, I think considering cangrelor, because you have immediate onset for P2Y12, or in selected cases, the 2B3 inhibitor is really important. But that's the standard way we would treat a STEMI or non-STEMI patient anyway.
Yeah. I want to clarify one point for everybody, and maybe we'll go around and ask each individual. When we say PPE, it might mean different things to different people. So maybe I'll have Perwaiz, you start by telling us when you're assuming everybody's COVID positive. So what's your PPE?
Sure. So our PPE is a head cover, a N95 mask, a surgical mask on top of the N95 mask, a surgical gown or an impenetrable gown, a face shield, a set of boot covers, shoe covers, and obviously gloves, 1 or 2 gloves depending on the person. And we are essentially donning and doffing in a designated COVID cath lab room. Obviously, those are for the patients who are truly positive, but every cath lab essentially is being taking care of COVID patients.
Got it. Okay. Is that different for anybody else? Fred, are you doing anything differently?
Not fundamentally. It's an N95 mask and a face shield. We have not been typically double gloving, and actually we haven't been going to a separate lab for the donning and doffing process. So that's interesting to hear. I think that our prevalence here is just so much different than it is for Dr. Mirage. That we're not sort of facing, at least right now, those sort of same issues. But I think in a place where the prevalence is so much higher, it makes sense. And this is the great thing about these roundtables. I mean, these are things I need to think about.
Mm-hmm. David, how are you doing it in Vancouver?
So I think this is fascinating, and this has come out on multiple webinars. I think we saw what happened in Italy and Spain. We were very fortunate, I think, like you in San Diego, Shami, that we had early mortalities, almost the same time as New York. And then because of probably some serendipity of the fact that our spring break, we were able to put social and physical distancing in before spring break, we really have not had a surge. We got up to about 1,500 cases, and then things just absolutely stabilized as far as hospital admissions, ICU admissions, and deaths. And now they've just been grumbling along at a low level. So we have one of our cath labs at each of the tertiary care centers in Vancouver is negative pressure. We would use N95 as we just heard for Perwaiz. But I must say the majority of our cases, we are just using regular, as you would in a standard cath lab, basically, which would be droplet level precautions. We're putting masks on patients, to Cindy's point, but we're certainly not escalating for all cases. So if we have a run-of-the-mill STEMI where we can obtain a history, we put a mask on that patient, we're still waiting for the rapid assays. As you know, it's Canada, so there's socialized medicine. We might be waiting for a while for that. We would be doing that as a standard STEMI case, but with droplet level precaution.
Got it.
So can I jump in here too? I think this is a really good point. So to bring up the concept of the registries that we're doing. So this issue and what you mean by PP is really important for us. We actually have a mix. We're probably in the middle, and we do have one cath lab that we have designated for the COVID positive patients. That is a negative pressure lab, and we do in that lab where you prepare it so you take everything out so that you can turn around the lab as quickly as possible. So we've done those kind of normal things, and then we wear N95 with a surgical mask over the top, and basically just like Perwaiz is saying. But to that point, we really need data. And I think one of the things from a standpoint of both SCAI and the Canadian Society is that what pushed this is to actually do a series of registries. So one of them that is, we call it an exposure registry. So we have about 10 sites around the country that have had a very high prevalence. And we're actually systematically looking and seeing if this level of PPE is actually protective. And I think if it is, then that will be reassuring. So that's in process. And then I think the second registry that we have that many people on, we can talk a little bit more, is the North American COVID Myocardial Infarction Registry, which is for all patients who are COVID positive or suspected, who have ST elevation, and whether or not they go to the cath lab, whether or not that they get PCI. Our goal is to have a comprehensive look at ST elevation and in COVID positive patients, and we'll be able to compare them to a really robust database with historical controls. And then the third is we have a registry that we're looking at mechanical circulatory support. So I think all of those things are really important. And we also have some survey things that we're working on that maybe Shami can talk to you about. But I think the PPE one and the exposure one will be really helpful as we go forward, so that labs realize what safe PPE is and that we do it more consistently.
Tim, that's a great segue into being able to share with everybody that we have launched this NACME registry with Tim and Payam up in Canada. It's a combined registry co-sponsored, I should say, by SCAI and CAIC, and also the ACC Interventional Council. We're all involved, and our goals are to figure out what ST elevation really means in COVID patients, and we're gathering data contemporaneously so we can share with all of you our findings. We are looking at an exposure registry to define the adequate PPE. Third, MCS use in COVID patients. And fourth and fifth are two surveys we're doing. One, what the impact of this pandemic is on interventional cardiology training programs. And secondly, what are cath labs doing around the country as figuring out what the impacts are on their operations, on their finances, on their ability to survive, and how do they ramp up again as the loosening of which patients are considered elective versus essential in our world of cardiovascular disease. So those are the 5 registries that we are, or 5 studies that we've launched in combination with CAIC. So maybe what we can spend the next few minutes, there are more questions. Another interesting question that a number of people have asked, so let's go to that. It's a clinical question, which is culprit only versus multi-vessel PCI. Both for STEMI and NSTEMI patients. So I'm going to go and ask everybody their approach, starting with Tim. Tim, what would you do for multi-vessel disease that goes to the cath lab in this era, both for a STEMI patient and an NSTEMI patient?
Yeah, so that's a great question. And I think based on the complete data that we know that in STEMI without cardiogenic shock that we should do complete revascularization. Of course, the timing of that complete revascularization is still whether you do it in the same setting, in the same hospitalization, or you actually come back. What I think is this would push me personally to be a little more likely to do it in the same setting so that we could actually do complete revascularization and have the patient out of the hospital. And I think, but that is always a decision about judgment. What are the risk territories? What's the creatinine? How challenging was it? I mean, if you get an excellent result on the culprit and you have another area territory, then personally I would do it in the same setting. And COVID might push me to do it a little more. I think with cardiogenic shock, that's culprit shock showed us that we're doing multi-vessel PCI is probably not recommended, or at least there's certainly questions about it. So I think that in that setting, I would adjust to the patient situation and do multi-vessel depending on what I think the risks are for that patient. Non-STEMI, likewise, I would try to keep the patient's trips to the cath lab at a minimum, and I would err on the side of as complete revascularization as possible as I could get. That's actually exactly what I did today with several non-STEMIs, and so I think it's prudent at this point in time.
Cindy, your thoughts?
Well, I agree in general with what Tim says in the non-COVID patient, but I'm influenced a great deal by my friends in Northern Italy. In Milan, high volume cath labs have been telling me that they have a lot of stent thrombosis. Of course, there's thrombus in the coronary. The patients are hypercoagulable. They might have multiple culprits, perhaps, that make you want to do it. But in general, I would not perform it acutely. And even in the complete trial, they allowed the second PCI was done within the first 42 days. It was not done acutely. And so I don't think we can extrapolate complete to saying that we can safely treat these patients acutely with multi-vessel PCI.
Okay. David?
So this might seem interesting because I spent 6 years of my life as co-PI of Complete with Shamir Mehta. We published it in New England and Jack, but we're doing exactly this, Cindy. And again, very clear here. These are on patients who we would consider just regular STEMI patients. These aren't people that with influenza-like illness that we're thinking are having COVID. But what is happening because of logistics and the fact that we're trying to keep this, we have 4,000 empty beds at the 5 tertiary care hospital system in Vancouver for this surge that has not arrived. We are doing more multi-vessel PCI, and again, in the same sitting. So at 2 in the morning versus bringing them back. As you know, we allowed people to come back inpatient or outpatient up to 45 days. We are doing more same sitting PCI. I don't know if that's the right decision. I would think that we're starting to tip because we're, I think, going to transition in this last 7 or 8 minutes to talk about reintroduction, which I think is a key topic for all of us of cardiovascular services. I think we've reached a tipping point, at least here in Western Canada. Shami, maybe you can speak to this, where we are starting to talk about reintroducing the cardiovascular service line, intervention, EP, cardiac surgery, diagnostic testing, echo, cardiac CT. And I think we're going to start going in the other direction where we'll go back to standard practice where you'd have your culprit treated, the next day you'd have your non-culprit treated, and you'd go home on day 2 or day 3. Thanks.
Okay, great. I would say what we're doing here, and the governor of California just yesterday announced the only thing right now that's loosened in California, 2 things I should say. You can go to the beach and you can go to the park. And secondly, the deferred cases can be treated. And that's partly because overall the strategy of isolation has worked in California. And so we are now coming up with strategies of how to re-engage and reinitiate our processes. What we are doing is COVID testing every single patient who's admitted to UC San Diego through the emergency room and every single patient who needs any kind of surgery or elective procedure, cath, EP, TEE. And we started doing that last week. And the plans are to do that next week and as we move forward. The only area we're still trying to figure out the best approach is what do we do for our non-invasive lab. And obviously we're not going to test everybody who comes to a clinic visit, even though majority of our clinic visits presently are virtual. So that's what we're doing at UCSD. And this is with about an inpatient census of 30 in our institution, but that's been flat for about a week.
So Shami, can I comment on this? Because I think this brings up a really, really important point that we haven't touched on. And if anything, this webinar shows you how many issues are really of interest to interventional cardiologists and all cardiologists. But that is the issue of the consequences of what we've done and the late presenting STEMI, so that we know that the data in the United States, Austria, Spain, all shown at least a 40% reduction in patients presenting with STEMI activations, an increase in out-of-hospital cardiac arrest, and as Pere said, not making it to the hospital, an increase in abdominal aortic aneurysm ruptures, patients who have been waiting on the list for TAVR with an increased number of deaths on patients who are on TAVR lists. And all of these are consequences of us not taking normal care of cardiovascular patients. So I think it's really important for us to let patients know it's safe to come to the hospital. You should still call 911. I think one thing that we have in common with all is we've created an environment in the hospital with COVID positive spaces and not. The testing is really in place, but we really have to put confidence in patients that they need to come to the hospital when they're having an acute cardiovascular emergency. And we have to get on with doing because what's elective and non-elective is complicated, and I think that it's we're seeing the consequences of delaying that care.
So Tim, you actually ended up answering a lot of the last set of unanswered questions. A lot of people were asking whether all of us have experienced a lower STEMI volume and end-STEMI volume during this recent pandemic, and you've recently published a paper showing that it's about a 40% reduction in STEMIs around the country in many different centers. So that's clearly a problem, and we need to get everybody back, meaning all our patients, back to get their cardiovascular care. As we're rounding out the last little bit, I'm going to go to each individual panelist so that we have about a minute each to give your final thoughts. And I'll start with Fred. Fred, what are your final thoughts?
Well, so I think that, a couple takeaway messages for me. One is that, this is, as I said before, a very regional disease. And so, you have the experience of Dr. Mirage, and you have the experience, in Utah and other places where it's less prevalent. And so, it's hard to sort of, give blanket guidelines. And I think the discussion about, culprit vessel, and multi-vessel is sort of emblematic of that. The other issue I would say is that, we put out our initial cath lab considerations for COVID manuscript, between SCAI and the ACC Council, about a month ago, and it feels completely out of date. And, a couple of issues that were brought up by Dr. Grinds, sort of emphasize that, that these sorts of programs and continuing to get data is so important. So, the fact that maybe we don't want to intubate as many patients. Our recommendation was not for elective intubation, but it was for the patient who was, on the borderline to think about intubating them before they got the cath lab because of exposure. But maybe there's going to be data that comes out to suggest that's actually harmful to, to intubate those patients. We have to sort of adapt to that. And I think the other issue that she brought up was this whole issue about stent thrombosis. I'd heard about this anecdotally. We need to understand that because it really could impact how we treat patients.
Great. Parade, your thoughts? Final minute.
Sure. So I agree. I think this is a very regional issue, and I think every region is experiencing different effects of it in terms of the systems of care. In New York, it's been inundation and everything from EMS services to hospital services. We're running at 60 to 70% above capacity of beds, and it's finally starting to decrease now. But it's been like this for a while, and so the concept of reintroducing typical normal cases is very difficult when our recovery room and short stay area are both COVID ICUs today. So it's obviously going to be different in every different place. The one thing I can say for sure is having taken care of these patients both in the cath lab and as a ad hoc pulmonary critical care attending in the ICU, we think we know stuff about COVID-19 and how it affects the cardiovascular space, and exactly what Tim's saying, we really don't understand it completely, and I think we need data to truly understand it. We're sort of flying by the seat of our pants. It's very possible that everything that we've known about non-COVID patients doesn't apply to the COVID patient, but we really just don't know. And so the only thing we do know is that we still take care of patients in the best way we know possible today, and in the way that our health system can allow it, and our systems of care can allow it based on congestion. And in other places, there isn't any congestion, so they can care for it very much more easily. But I think it's very important. I think we have to learn from each other. And I think if anything that we can say that we take a silver lining out of this COVID pandemic, with the unfortunate realities of it, is that we're all coming together. We're all trying to learn together and try to exchange information and knowledge. And that's, I think, the best way to move forward.
Any final thoughts?
Well, I agree 100% with you, Pervase. I think that we need more data, and that's why I would encourage the interventionalists on this call to take your patients to the cath lab. I think we know a lot about how to protect ourselves. We're not up there by the face. We have lead shields between us and the patient. We have an image intensifier that's protecting us as well. And if you, consider even double gowning, double gloving, double masking, wear your lead glasses. And I don't think we need to be as afraid. I'm hearing so much about hospitals where the interventionalists are not giving thrombolytics and they're not taking anybody to the lab. And the one thing I can say is that I don't think that that's a good approach. I think we need to continue what we did before, at least to bring them to the lab and make a decision.
Great, thank you. Tim?
Yeah, so first of all, three quick things. First, I think that one of the positive things about this is that the cooperation with the CAIC, SCAI, and ACC, Interventional Council, but really all ACC, has been phenomenal and is really, for interventional cardiologists, a really positive thing. Number two, we need data, so I really encourage everyone out there to participate in the registries. The NACME, and the MCS, and the surveys that we're going to have are really important so that we actually have real data. And then the final thing is do best care. Really maintain the high standards of care with guideline-based care that we know works well for our patients.
Thank you. David, as we wrap up, I'd love to hear your final thoughts, both from your personal experience as well as CAIC.
So completely agree with what was just said. Very important points. I think, Shami, we're on like our 19th webinar now globally. And the common theme is 24 months from now, we are going to be judged on how we balanced preserving capacity for COVID in areas where there's a surge, like where Pruways is, and then what we're doing for patients with untreated cardiovascular disease in the community, where we know they're having morbidity and mortality. And when we look back, we're going to see that excess morbidity and mortality. So that safe reintroduction, I think that's a conversation. It's very regional, but it is very appropriate. And how we're going to test, how we're going to use PPE, because if we just talk about everyone in the whole hospital, porters, booking clerks, any procedure, colonoscopy, lithotripsy, everyone's using full PPE, that is going to be a real challenge as we move forward. I think the final piece, Shami, as I said, is this collaboration's been fabulous, but I think things are changing so quickly that we'll likely be having another discussion with this group very shortly.
Great. I'd like to finish up by thanking all the panelists, my co-moderator, David Wood from CAIC. I do think we're in unique circumstances, and we are handling it in a unique manner of collaboration, working together as a group, and hopefully all of you who tuned in to this webinar can take away our key messages. We do believe in primary PCI as the first-line therapy for patients having an occlusive, a STEMI that is felt to be associated with an occluded artery. In patients who are COVID positive or probable, and in whom there's uncertainty, get additional imaging, get additional diagnostic testing, and we still feel that those patients should go to the cath lab to get a confirmatory diagnosis as indicated. And when it comes to regional systems of care, this is the time for primary PCI centers, referral hospitals, EMS to all get together to come out with unified ways to handle this. You don't want to figure out how to do this when you have the patient that you need to manage in a sick patient to manage. As an anecdotal final example, we've got a call today from a small community hospital where they feel that there's a patient who needs VV ECMO. They don't have the capability, and we are flying or sending our team over there, getting emergency privileges to initiate that and transfer the patient back. We've never done this before with this particular hospital in the past. And so in uncertain times, we find ways to all collaborate and take the best care of our patients. Thank you for joining us. And there will be additional webinars coming from both of our organizations in the near future.